In today's episode, I'm interviewing an attorney that specializes in childbirth cases. At various points in this episode, we discuss adverse outcomes that can occur during pregnancy and childbirth for both birthing people and their fetuses or babies. So if you are planning a pregnancy, pregnant or currently postpartum, or frankly, if you're in any stage of life and this topic is not what you want or need to hear at the moment, please listen at another time or just skip this one. So, while this interview is different in nature, if only because it may be the first time I'm interviewing somebody who is neither one of my personal clients nor a healthcare worker or birth worker, I think that today's guest might actually bring perspective that both providers and healthcare consumers may want or need to hear. With that said, let me tell you a little bit about Gina Mundy. Her work in this area has led her to do a deep dive into the hows and whys of mistakes that can occur during labor and birth, which led her to write a book called A Parent's Guide to Safer Childbirth. She believes that there is knowledge that all pregnant people should have that can help them better advocate for themselves and their babies, ultimately leading to better, safer birth experiences. And she's here today to share some of her wisdom with us.
And thank you, Tanya, for having me. I'm very excited about our conversation today.
Me too. I'm a little nervous, but I'm also really excited. I'm just nervous because I'm doing something different than I've ever done before.
I know, right? I think we all fall into that same trap. Like it's just easy to do what we know. Yeah, but the path less taken or the harder path can sometimes be the better path. So
absolutely.
I'm excited.
Absolutely.
And I'm pretty chill, so it shouldn't be too painful for you.
Awesome. Okay, so let's start out by just let you tell us a little bit about yourself. I'm curious if you're a parent. I'm curious if your own birth experiences kind of led you down this path. Just tell us a little bit about whatever you're willing to share about yourself.
Thank you. So I am a mom of 3 kids. I have 2 older daughters who are now 20 and 16, and my little man is 10. I've been married for 21 years. I live in Michigan. I have also been an attorney specializing in childbirth cases for 21 years. And just so your audience knows, and I'm sure many of them do, but the cases that I'm involved in as an attorney involve the birth of a baby when something goes wrong, whether it's a mistake or a complication, and baby is not born healthy. You gave the trigger warning, so I can say, I usually do stay a little fluffier, but babies born with a brain injury that's permanent in nature, or babies may pass away during childbirth, or sometimes moms pass away during labor and delivery. So as the attorney, I come in and I find out what happened, what went wrong, why. Probably more importantly, a big question is what should have been done. So, mom was around to raise her baby or a baby born healthy. Those questions have taken me across the United States many, many times, meeting with different delivery teams, whoever that may be, basically hashing out every aspect of labor and delivery. Now, I don't have any training medically. However, my life the legal world is it's all the medicine. And to be quite honest, I'm a little bit jealous of healthcare workers because, they get to see the good and the bad. I only see the bad. I've had to see the bad for 21 years. And not only do I have to see the bad, but these are cases that take years to get through the system. So it's years of analyzing every aspect of the bad. So let's see, about 19 years deep into my career, my niece was pregnant. It's my sister's oldest daughter. She was having the first baby of our next generation. And she's the introduction to the book because she is the reason that I wrote the book, but she just had a very scary childbirth. And it was a childbirth that played out very similar to a baby case. And just so you understand too, when these baby cases, there are reoccurring issues, reoccurring facts. again, that have keep occurring and that have, continued to occur over the past 21 years. So I was 1,100 miles from her that day. So, I'm on the phone trying to help them. It's too late in the game. She's already in labor. Baby basically, I'll back up a little. I was 1,100 miles away, and my phone rang, and it was my sister, and we were like, oh, just please tell us the baby's been born. So we expected to hear the good news, and instead it was one of those moments you'll never forget where you are. I was in my kitchen surrounded by my kids, and I answered the phone, and it's my sister screaming hysterically, the baby crashed, the baby crashed. So I ran out the door, the front door, so, my kids couldn't hear her. And I had to sit and I listened to her cry for about 20 minutes. Of course, my legal brain went into what could have been done different and whatnot. But as I listened to her cry, I went from this legal analysis to human analysis. And I realized that, this is how the families felt. Over 20, at that point, 19 years, I had heard, the families tell me about this transitional period, life before baby and life after baby. And, it's just, I'm like, am I in this? But you feel for them. And it was just, I don't know, it was like this emotional connection that I had. But we were lucky, and we got about 20 minutes later the news that baby would be okay. But that stopped me in my tracks. It pulled me out of my grind. It was a Friday afternoon. It was March 17th. It was St. Patty's Day. So I had the whole weekend to kind of marinate, in what just happened. And it made me think, well, what if I'm 1,100 miles from my kids when, they go to give birth to my grandkids? Because I'll tell you, as an attorney specializing in childbirth cases, how I'd prepare my family for childbirth is completely different than how a traditional family would prepare. So I started to write down, everything. Probably most important, probably something that's so important to this episode is the reoccurring issues, the reoccurring facts. So, hey kids, if, this happens in your labor, this is what you have to do to make sure there's no complications or mistakes. But once I started writing, I realized that this is information that could, really not only help my family, but help families across the world. And then not only that, even if you go on my reviews on Amazon right now, I have so many midwives, labor and delivery nurses, doulas love my book. It's ended up being a book that really even healthcare providers have learned from and really enjoyed. There's a lot of the midwives, and these are reviews. I don't even know these people. I know one of the midwives I just read, she's from Germany, and she recommends my book to every single one of her clients. And labor and delivery nurses love my book. I had one read my book right before I published it. Did I miss anything? Did I get it right? What do you think? And I remember that conversation we had after she read my book. She's like, Gina, if every patient knew this stuff walking in, she's like, my job would be so much easier. Because, that way, I know labor and delivery nurses a lot of times, they're teaching patients bedside. And it's, you have mom who's, in a different state of mind in labor. It's hard. So, so basically June 2023, I published my book. And it was about that time, while I was writing it too, but I kind of made the decision, not only to get involved in the aftermath of something going wrong, but trying to get involved beforehand to prevent these mistakes and complications, that I've seen now for 21 years. I'll tell you, the hardest part of my job is the day I sit down with the families and I go over the day their baby was born, the day they lost their mom, the day they lost their wife. So it's hard. So I wrote this book hoping to spare other families of, what these families have had to endure over the years.
So that's really the essence of why I went with my gut and had you on, because I could tell that what you were trying to do wasn't just scare people or lay out the facts of what can happen after the fact, but I could see, not that I fully understand how you go about it yet, I'll certainly let you tell us more about that here in a second, but I could see that you were trying to take all this experience and all this pain that you've witnessed over the years and find an approach to say, how can we use this to prevent this stuff? And so while I'm fascinated and I want to hear more, I can't quite wrap my mind around how someone from your perspective comes to this and does it in a way that makes it easy for people to consume. Because, pregnancy is such a time of information overload. And there's so much anxiety that hits people in part because of that, but also other reasons. And now they're balancing that overload against their anxiety. And I guess I'm just trying to figure out how people interact with this book on the consumer side of things. I'm starting to understand already why the providers are loving your book. And I think that that's great because it's probably helping all of us think in the various ways that we know medicine has moved to try to be more preventative. But talk to me more about how this works in terms of how you approached the book and how readers can approach the book who are on the healthcare consumer side of the equation.
Great question. So listen, because of what I do, I know that when you speak to somebody who is expecting a baby, you do have to be careful. I learned that pretty early on in my career. I would talk to some people who are expecting and ask them questions, and they would almost like kind of turn deer in the headlights to me. And I'm like, oh, they're kind of shutting me off. So I learned real quick how to make sure you're very careful when you speak to them. So when I wrote the book, I understood, how important this information is for families to understand and know, to give them a sense, a heightened sense of heightened awareness, help activate their intuition. So the last thing I want to do is scare them so they don't know. Because I'll tell you in this book, one of the number one lessons, and it's from the families, is, they don't prepare, they don't get ready. So, if they have this information, it will help them prevent the mistakes that I see. And listen, when you lose a baby to a preventable mistake, I don't know how they move on. So I wanted to be very, very careful when I wrote this book, not to scare anybody. And so I spent thousands of hours, 14 months writing this book, and a big focus of it was doing it in a way that would not scare anybody. Before the book was published, I gave it to 6 pregnant beta readers, and beta readers are the people who will read your book before it's published and give you feedback, through your questions. But my number one question to the beta readers was, is this book scary? And across the board, all 6 were like, no, this is not scary. Now, there was one part that kind of was concerning, so I did change it. But she was really nitpicky. She was my first time mom. She was younger. So I did change it according to what she wanted. But I also, I may state something, and then I had editors who worked with me on making sure I do not induce panic in expecting parents. So they would go through my book and be like, Gina, you have identified a problem, you have to solve it. You can't say, for instance, the number one issue, the number one fact in a legal baby case is, the drug Pitocin, which is used to induce mom's labor. You can't say that and then be like, so good luck. Then there's a whole chapter on how do you have a safe Pitocin induction. And it goes through the fact that this is a drug that it's, been involved since my first case in February 2003, the extensive research I've done on it, traveling the country talking about this drug with different providers, patients, you name it. This is how you have a safe Pitocin induction. So I really worked with the editors, the beta readers, myself, just trying to make it more objective. And it's more about how to make sure things go right, not about what can go wrong.
Are you pregnant or a new parent looking to ensure a better postpartum experience? Or are you a birth worker looking to improve your postpartum care skills? Check out Thriving After Birth, an online self-paced course by me, midwife and educator Tanya Tringali. It's 10.5 hours of video content featuring experts in lactation, mental health, pelvic floor health, pediatric sleep issues. You also get worksheets and a workbook, as well as options to have a one-on-one session with me. Sign up at motherwitmaternity.com/thriving, and let's improve postpartum care together. That's a really great way of saying it. So, okay, on that note, can you tell us, I know we don't have all day, and nor do you want to read us your whole book, but tell us what some of the things are, whatever examples you feel are, most important to get this discussion started, where there is a problem that can be identified quickly by the birthing person or their family in the moment, and then what they do about it, so that we kind of understand the arc of how you approach this.
So it's being prepared. So, once mom goes into labor, she's like in a different state of mind. She has to mentally and physically focus on delivering babies. So everything is about preparing and getting ready during the pregnancy. But not only that, because mom is in this different state of mind and needs to focus, it's also, hey, dad, grandparents, whoever's going to be there, this is information they can use too, again, to help just protect mom. And it's things like, for instance, I just talked about the number one fact in a baby case. That's the drug Pitocin. How to have a safe Pitocin induction. That's going to include also, if you're pregnant, you should really just have this discussion, because you may not want Pitocin. However, sometimes, like in the introduction of my book, if you're 37 weeks and there's concerns about the baby, you have two, and you're not in labor, but baby's in trouble, you got two options. You got a Pitocin induction if baby can handle it, or C-section. So just knowing Pitocin ahead of time is huge. And then talking to talking to the doctor. Okay, well, what are your orders for Pitocin? Pitocin conceptually is very easy. Literally, they start typically at 1. The typical order goes to 20. Are you going to go up by 1? Are you going to go up by 2? I've heard them go up by 4, which scares me, and so forth. But it's, here's the information. And then having a birthing plan where, you have it laid out in your birthing plan, what that may entail. Again, there's a chapter on this that explains it. And as the attorney, the purpose of a plan, the birthing plan, is not so much, what's in the plan itself. It's more of the act of preparing the plan.
Yes.
Because that's going to get you ready for labor and delivery, because you're going to have to marinate in different decisions and make decisions and whatnot. And the fact that you cannot plan labor and delivery is the exact reason you need a plan. Again, to plan for your different options and what you may expect. Because I'll tell you, in these cases, decision-making is incredibly important. These families are minutes from a healthy baby. Minutes. It's awful watching these things unfold. And so, the good decision-making and understanding that mom is ultimately the decision-maker. The delivery team are their medical advisors. And it's mom who makes those decisions. I mean, no one's starting PIT, IVs, nothing without mom's consent. So that's Pitocin. So another common fact, and this one is good for everybody. A very common issue in my cases, a busy labor and delivery unit. In Michigan, we're crazy busy May, June, and July. And then in July, a lot of the institutions around here are teaching institution, and they got some new residents. So understanding that, the units get really busy. So a family or consumers, they have to have an understanding of what's going on to help them work with their delivery team, or maybe get a doula. I am a huge fan of doulas, and I love throwing this out there. I've never had a doula in a childbirth case. I repeat, I've never had a doula in a childbirth case. This is huge. If a mom would have even talked to a doula during childbirth, if a doula stepped in the labor and delivery room, she would be a fact witness in my case. They're not present in the cases because I do believe they help families to bring babies, into this world without the complications and mistakes that, I see in my cases. So, but chapter 11 goes over the busy, labor and delivery unit, that being common, but then kind of what, you could have the dream team delivery team, but it's like anything in life. If it's a day where you're moving at the speed of light, it's hard to give, everybody the attention that they may need, especially during something like a Pitocin induction. But anyway, so that book, it goes over kind of working with the team and what, everybody can do. Another common issue in the cases, and this is very important, is most mistakes or complications occur after mom's water breaks, whether it's spontaneous or artificial. When that water is intact, babies, it's like they're assuming that when baby comes into hospital, this is also assuming that baby's, everything's fine. But yeah, most things when they go wrong or there's a complication or a mistake, it's always after the water breaks, which makes that an incredibly important decision, not only for families, but, healthcare providers, because they're the ones making the recommendation. Because I have a lot of cases where they're like, especially during a Pitocin induction, they want to break the bag of water and then boom, things go south. So they're important decisions that I don't know if people really understand the gravity of it. But me, that's what I see in my cases.
You just gave some fantastic examples, and I'm going to stand on my soapbox for just a minute, which I have to do every episode, because we midwives, right? We are a very small but dedicated subset of the larger profession of people who catch babies in this country, right? And so much of what Gina just said is stuff that midwives more instinctively do, right? Our focus is on maintaining, when at all possible, the elements of what we like to call sometimes physiologic birth. Some people just call, quote, air quotes, natural birth, whatever. But our emphasis, regardless of what setting we're in, is to try to maintain that normalcy, which means less use of Pitocin when we need it, lower doses of Pitocin, not breaking water as quickly as possible. I could go on. The birth plan discussion, huge. She said some really important things that I just want to put that midwife medical provider spin on. I can't tell you how many clients I work with who are trying to find the, quote, right birth plan template. And I'm like, it doesn't matter. The template doesn't matter. That's just the fluffy stuff. It's whether it's pretty or not. The every birth plan, for the most part, that you can find on the internet is going to have the same list of questions to ask yourself or boxes to check off. It's the thought process. I make people do this so that I can figure out where they've put their thought in, where they haven't, where they have a preconceived notion that's correct or not correct, and we can work it out as a team and figure out where we're going to land at the end of the day. The other thing she talked about is that we, the medical team, we're not there to make decisions for you. We're your advisors. You have to make the decision. And the majority of people love that about what medical providers and midwives do. But every so often somebody wants us to make that decision for them. And then that's difficult. And I know it can be hard to make these decisions for yourself. You feel like, well, you know best, so just make the decision. That's not the best way to do it. So sometimes pregnancy is the best time to practice that skill of standing up for yourself and advocating for yourself. I love so much of what you just said, and I'm starting to understand why your book is not scary. And I was so scared myself to have this discussion today because I was worried that you were going to scare the daylights out of my clients. And I'm totally getting it now.
And I do. Okay, so I just love what you said. Two things that just stuck out right now. So love this. You have very lucky clients, by the way, clients or patients. But anyway, the birth plan is so important then to talk to your provider about, or midwife beforehand. That is incredibly important. And the other part of what you just said with the physiological birth, let me tell you, vaginal, spontaneous birth, skip the drugs, skip the interventions, those cases are few and far between. Rarely do I see that. So if you do a spontaneous vaginal birth, you're less likely to have the complications that I see. So please listen to Tanya.
Well, and it's funny because I have a line that I say to people that can sound really snarky if they don't get me, but I say it with lots of love. And that is, if everyone put as much energy into staying home in early labor as they put into arriving at the hospital on quote unquote on time, the outcomes and everything would look a lot different. But everybody's so worried that they're going to have their baby at home or in the car. And I'm like, please, if your baby just falls out, God bless you. Because that's not how it works for 99.9% of people. I would pay good money for my baby to just fall out. Put me out of business. Make me not needed. But that's just not what happens. The babies that come that easy are the easy births. those are the ones where moms and babies statistically are more likely to be fine. I'm not here to poo-poo the person who had a precipitous birth and had a difficult experience or potential bad outcome, because obviously it can happen. There's no absolutes. But the situations that are most difficult for us as providers and for patients are those very long inductions, usually for medical causes. Now, what I also want to say on the flip side, as much as I totally agree with what you're saying, if you are a candidate for a spontaneous birth and somebody's offering you an induction, yes, I completely agree. Please stay on that path of that spontaneous labor. But we are living in a time, and this is just truth and fact. We are living in a time where we're seeing complications increase. We are seeing more hypertension during pregnancy. We are seeing more diabetes during pregnancy, and we as medical providers can absolutely do better and help reduce that. But in the moment, when we have a pregnant person who's term and we are faced with these complications, that absolutely increases the necessary induction rate. There are reasons we need to induce those people, and that's just two examples, that's not everybody. But then we're increasing those complication rates as well. So we have to keep that in mind. It's not so simple as saying, just go get that spontaneous labor. And so you need to know who you are in that equation based on your risk factors. So I agree, but I just want to make sure that people know that that may or may not include you based on what's gone on in your health history, your OB history, and leading up to your labor.
Well, and two, I mean, those are medical inductions, elective inductions.
Yeah. The problem is that zone has become so gray, right? And I'm curious if you have thoughts about that. There are so many inductions now that, it's really almost hard to tell. Is this truly elective? Is this medical? I'll see a medical indication, but then on paper, we're still calling it an elective induction. It's still your choice. Right. There's a medical reason here that we can use to bolster our rationale for offering the induction, but it's still your choice. Do you see what I'm saying?
We hope you're enjoying the Mother Wit podcast. If you are, please rate us and leave a review in iTunes, Spotify, or wherever you're listening to your podcast. Thanks so much. Now, back to the show.
Yeah. No, and I mean, the records I review, I mean, it's either it's an induction due to hypertension or elective induction. But, I'll tell you, with the whole elective induction thing, doctors are so different, with how they're handling these. I talked to a doctor 2 months ago now. And he told me that the standard of care requires him to offer his patients an elective induction at 39 weeks if they're a good candidate, if they're a candidate for it. And I'm like, what? Then last week, I was talking to a doctor who's very familiar with everything that I walk around and advocate. And he actually told me, because of all the cases, because Pitocin is the number one fact in these legal cases, his practice is shying away from elective Pitocin inductions, meaning they're not offering it to patients. So according to the other doctor, he's violating the standard of care. My personal opinion in it is, given what I know, I think it's a violation of the standard of care to offer every single patient who's a candidate for an elective Pitocin induction. I think that's a violation. I think that's unreasonable given what I know. Given that that's when mistakes and complications occur during labor, no, I don't think so.
Well, and this is because, and you probably know this, and our listeners, I just want to make sure that, especially on the healthcare consumer side of things, there was a big study called the ARRIVE trial, and it's
in my book.
Yeah, okay, great. That is a big reason why we've seen that pendulum swing. This study came out and said that we have better outcomes when people are induced at 39 weeks. And so, lo and behold, the induction rate skyrocketed. And I'm guessing what you're starting to see is the pendulum swinging back, but not everybody's going to swing back as quickly as everybody else, and some people will never swing back, et cetera, et cetera. So I think that's what's going on there.
Yeah. No, yeah, they had a ARRIVE study. Yeah, I'm not a fan of it. Not a fan of the conclusion either. But if you go to the Pitocin, the drug insert, go to the manufacturer's drug insert for Pitocin. If you haven't read that, you should really read that. It's interesting. It's very, very different than how they practice. And I go through a lot of that in my book, but, right at the top it says not to use for elective inductions.
I just want to pause here because we have talked a lot about, in a very specific way, Pitocin induction. And I just want to point out that the vast majority of people who are induced, in case this is confusing you, their induction is actually started with what we call a cervical ripening agent. And that is the ideal way to start an induction unless someone comes in with an already very ripe cervix. And just to provide some clarity on that, what do we mean by a ripe cervix? We mean that it is soft. We mean that it has thinned out. We mean that it has kind of rotated anteriorly. It's a grading system that we use to determine if someone needs cervical ripening, and there are a number of ways to do this. There are a couple medications we commonly use, and it can also be done without medications, sort of mechanically we call it, and that's using a balloon. So in case you are hearing about these things, I just want to make sure that you're hearing these other words as well. So that's Cytotec, or also called misoprostol. That's one medication. Another one is called Cervidil, and then we talk about a balloon for the mechanical ripening. So I just wanted to put that out there because I feel like it really got left out of the larger conversation. So if there are pregnant people who are starting to read and pay attention, or somebody who just had a baby and they're like, this doesn't sound like how mine went, just wanted to put that out there. Okay. Hey everyone, it's me, Tanya, your host here at the Mother Wit Podcast. You know I sometimes invite my clients on the show to talk about their birth stories and postpartum experiences, but I want to tell you a little bit more about what those clients and I actually do together. I started MotherWit to help people in the perinatal period achieve their health and wellness goals. That means whether you're hoping to conceive and struggling with high blood pressure or high blood sugar, or you're having trouble managing anxiety or depression in the postpartum period, or maybe you just need support and advocacy between prenatal or postpartum visits, I can help. Get a discount on your first consultation with me at motherwitmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. I'm looking forward to working with you and maybe having you on the show too. What are some of the skills, if it can be put this way? If it can't be, we can skip it and move on. But what are some of the skills that you want people to learn before they're in labor so that they can be a more active participant in this process? Because I'm assuming that we have to have layers here, right? There's the knowledge that you want people to gain, and that's obvious. But I'm assuming there are some actual skills, if I'm saying this in a way that makes sense for you.
Yeah. All right, ready? Healthcare providers, earmuffs. I have a huge chapter on this, and I believe that every single parent needs to understand what their baby's heart rate means. I've had doctors testify. I included the testimony in my book. Gina, the only way a baby can talk to me during labor is through their heart rate, which means if parents can understand the heart rate, they can understand how their baby is doing during labor. Again, more of working with your delivery team or whatnot. But everybody has to remember, baby's inside mom. When the mom's in labor, there's two patients. There's baby and there's mom. Mom's easy. You can look at mom's in pain. You can see it. Mom can communicate. There can be a diagnosis and a plan. It's different with baby. Baby's inside mom. And let's say the water breaks. And how's baby doing? Or Pitocin induction. People have to remember, contractions not only suck for mom, they suck for baby. Listen, babies are made to handle contractions. Nobody freak out. Babies are made to handle spontaneous, natural contractions. So getting the Pitocin artificial contractions to mimic spontaneous one, that's where people get into trouble. They have a hard time, getting it to the sweet spot where you can mimic it. But, when there's contractions so baby is in the uterus hanging out with their lifeline, the umbilical cord, and then the placenta, surrounded by fluid until that breaks or comes out. There's a contraction. The uterus is contracting down on baby's lifeline, and the placenta. So when that happens, blood flow or oxygen stops going to baby. again, completely normal. Completely normal. But with Pitocin, again, the contractions, if they're too close together, that can start affecting baby. So it's good for parents to have an understanding of that. Also, if there is a concern about baby, it almost always starts with their heart rate. So that's always okay, there's a concern about your baby due to their heart rate, so we're going to go do this intervention, or we're going to make this recommendation. So if you understand square one, the baby's heart rate, which is the basis of so many recommendations by the delivery team, that again, it's going to streamline communication. They don't have to sit and teach you bedside that the baby's heart rate keeps going down as you contract, so that's bad. Or whatnot. So I have an entire chapter on how to read a baby's heart rate. And I did it too, because as a childbirth attorney, that's the first thing I learned how to do. That is an issue in every single case, is the baby's heart rate. I can look at a baby's heart rate. When I get a case in, the first thing I look at is the baby's heart rate. And I can go through that strip and I can tell you if baby's a rock star or if baby's struggling. Why wouldn't parents want to know this? But I know the medical community has really kind of kept that information like that to themselves. Now, some of the nurses love this. They're like, please, thank you. But the baby's heart rate is so important because it is the number one way to see how your baby is doing during labor. Again, which is super important if it's like a Pitocin induction, there's concerns about your baby, or whatnot. So that's probably the biggest thing that I like parents to know. I like parents to know the common mistakes, because obviously, if they know Pitocin, that's when complications can occur. Then they can make sure they have the right things are done for their induction. What else? Just the importance of their delivery team, understanding that the delivery team, you guys are ultimately, they are, mom's the decision maker, and the delivery team in the cases are responsible for bringing baby safely into this world. So just understanding the different components of a delivery team, how the doctor heads it, making sure they pick a good doctor and what really that means. In my cases, I've analyzed OBGYNs now for 21 years. So there's a whole doctor analysis that goes into it, because I can't stick a bad doctor in front of a jury. So, I go through, the important parts of doctors and what they really need to know. Like in every case, there's about 20 questions we ask every doctor, and it could be to bolster their credibility or discredit them or, whatever. But I'm like, families, you need to find out these 20 questions. And it can be stuff that they can find on the internet, or maybe stuff that they have to ask their doctor, and it's good stuff. So I would say, knowing having a plan, like you said. And then, again, like Tanya said, please talk to your provider. Make sure you guys are on the same page. They may want to talk to you about something. Make sure maybe if there's a misunderstanding, whatnot, but, that's another big thing, is talking to your provider about your plan. It's 14 chapters. Chapter 1 is, this is important. Chapter 1 are all the lessons from the baby cases. It's a lesson we can learn from the past to prevent it from happening in the future. They're lessons, whether they're lessons from the families, the delivery teams, the medical experts, they're all there. And then basically each lesson is a subsequent chapter. So when I say number 1 lesson, you got to prepare and learn about childbirth in order to make good decisions. Because like anything in life, you're going to make better decisions if you know about something, if you're prepared, versus having to decide on something when you know nothing. So then chapter 2 is everything I find important about childbirth. So when I get a new case in and I'm like, is this good care or bad care? These are the things I rely on. And so I did that chapter to give families a good foundation of really what they need to know to help them make those good decisions.
Yeah, and in essence, what you're saying is like, a plug for the most basic thing we have out there, which is everyone should take a childbirth education class. The problem is not all childbirth education classes are created equal. And I talk about this a lot with people, and probably on this podcast before. Not everyone, I'm sure, but certain hospital-based programs, they are doing a little less childbirth ed than they are getting you to like fall in line, so to speak, right? So when you take a class put out by, a nurse who works at a particular hospital, whether they are doing it consciously or subconsciously, I don't know. I don't always know. But I know from what people tell me that they're kind of being shown, I hate to say it this way, but like how to behave, how to be a good patient. And that's not what it's about, right? So I highly recommend people take a childbirth education class that's unaffiliated from the hospital. And of course, that creates a financial barrier for many people. I get that. There are also places that are disconnected from hospitals who do scholarships and various other things if you show need, who have sliding scales. So don't throw in the towel too early, right? So sorry for the people out there who work in hospital-based childbirth ed programs. I'm sorry if I'm slamming you, and if you have a different way of approaching this, feel free to share. I'll air your comment on this podcast. So there's that.
There you go.
So there's that piece of the puzzle. I do think that you are onto something here. It's like it's education, education, education. And I do see a lot of people come into labor and delivery, and it still surprises me how many people didn't take a class and how many people I meet maybe for the first time in labor who, if I say to them, what was your plan for this labor? The most common answer I get is, well, we'll just see what happens. So if I say, were you planning to have an epidural? We'll see if I need it. What I can say from a statistical standpoint of having watched thousands of births in my life, thousands upon thousands at this point, anyone who doesn't come in committed to a path will fall off that path. It is very rare that somebody ends up having that like perfect, easy-ish birth who didn't work really hard at their planning for that. Because some of that ease, yes, some of it is some people's bodies are just meant for this, absolutely. But part of it is mindset. And when people aren't prepared for pain, they don't handle pain as well, right? Like there is preparation for managing pain that keeps you away from the epidural and this idea that sometimes is called the cascade of interventions, right? We use that phrase, it's a little loose, but there is some truth to that, for sure. And I think that's kind of what you're getting at, is like, how can the consumer stay off of that cascade, stay away from that cascade? And it starts, in all reality, it starts before you're pregnant, if you can get there. It starts with optimizing your health before you're even pregnant, and then optimizing health throughout pregnancy, and so on and so forth. And that's the work that I do with people that's really intensive, that's like the subscription-based stuff that I do outside of my clinical work. Because I know that that's where it's at, and I know that it's an enormous time investment. People have to be very dedicated, and their healthcare provider has to be equally dedicated.
Yep.
So anyway,
Exactly.
there's layers and layers to this. So I think you also really touched on choosing the right provider. And I think one thing we don't talk about enough is that, like, you can change providers. You don't have to stay with the same provider.
No, that's in my book.
Yeah.
You dude, they had your delivery team, really. I mean, they're the ones, they're this, so they make the recommendations, or sometimes, if you guys, everything's going hunky-dory, obviously the midwives, if you have a midwife involved, I love it because you guys are really hands-on with your patients. You guys can make the recommendations, but a lot of times, I don't know how it works with you guys, but I know in a lot of practices around here, the midwives running the show really may update the physician, but if there's, they have like a criteria, if there's some kind of issue or something, then doctor comes in. But if there's some kind of issue and doctor is being contacted, then they're obviously making very important recommendations at that point.
Yeah.
So, I mean, the doctor and provider, I mean, they're ultimately, they head the delivery team, again, which is responsible for bringing baby safely into this world. I mean, so it's the providers. I mean, their care is just picked apart during, the recommendations are picked apart a lot. So it's important that, you have a good provider and one that you click with.
Yeah.
It's so important.
Well, and on that note, aside from clicking with someone, there are other things that you can look for. So you want to work with somebody who has a really collaborative approach, who's happy to involve other team members and other professionals in the space. So if it's a midwife, you want to work with a midwife who has really good relationships with doctors. Sometimes that midwife works inside of a larger practice that has physicians. Sometimes that midwife may work completely independently, whether that's a home birth practice, a birth center practice, or even a hospital-based midwifery practice. And the physicians that they tend to use as their consultants have their own separate practice, but they have a very good working relationship. We call that collaboration. That is absolutely key to having a successful birth, whether you're working with a midwife or not. And I think it's important for people to know that there are things that we do to try to keep our patients safe, right? It's not just willy-nilly, even though these cases exist and they happen. In the moment, especially in a hospital setting where we're working with an interdisciplinary team, we do something that we often call a huddle, which is like, okay, guys, let's all just talk about where we're at with this patient care, and let's get everyone's input. And that might involve the midwife, the obstetrician, the anesthesiologist, the pediatrician, everybody, so that everybody gets an update on where this patient's at and what their needs are and where we think we're going. And that keeps us all accountable to each other and to our patient, right? And really good ideas emerge from those huddles. Likewise, when something doesn't go perfectly, that same team does what we call a debrief, so that we can learn from what we did or didn't do right, be honest, be upfront, face it. We have to deal with the emotions too. Don't think that we're immune from this. This is hard work for us when something goes wrong. You know, when Gina first started talking, she said she kind of envies us because we get to see the good and the bad and she only gets to see the bad. And that was really interesting to me to think about, because I think what happens for us is the majority of births go well. And most of the time we have happy experiences. And so we tend in the medical world, I think, to be blindsided by those bad outcomes, because we aren't the people who work in the emergency room or in the critical care units where we're seeing a lot of sick people often. We are seeing a lot of healthy people, and our job is to keep people healthy and have these wonderful, happy moments at birth. So it's really hard for us when it doesn't happen that way. So those are just some thoughts that arose as you were talking that I wanted to share from my perspective.
Yeah, no, those are definitely some good thoughts.
This has been so wonderful. I am really hoping people will read your book. I want to give you an opportunity to share any last minute takeaways that you might have that you really want to leave people with. And then, of course, I want you to give people all the information that you want them to have so they can find you and your book and really engage with you if they'd like to.
Oh, thanks, Tanya. Yeah, so pretty much this is all the information always about me is going to be at ginamundy.com. You know, even my podcast, the Childbirth Attorney podcast. I mean, that the purpose of that is to help parents have, healthy babies by avoiding mistakes and complications that occur. So even listening to a podcast, that's free. That's for everybody. I don't get paid for that or anything like that. This is information that, it's just a different perspective. So I have some really cool guests on. I've done a solo show where I just did it myself, directly talking to dads on how they can, what they can do during labor and delivery. Because it's funny, I have a lot of labor and delivery nurses, and they're like, well, dad's sleeping, dad's playing Candy Crush. And I'm like, no, dads, no, we're gonna participate and help. Just again, working with the delivery team here. If you get to notify them or just understand what's going on. If your wife has to make an important decision, working together, and whatnot. So that's some good information there. Obviously, what's in my book. On my website, I do have chapter 1 on there for free. Because I do believe that is such an incredibly important chapter. Again, being a lesson we learned from the past to prevent it from happening in the future. So no matter what, just parents, providers, everybody, getting through that is important. But again, just going back to where everybody can find me, again, the best way for the podcast, the podcast I think is on all major platforms, YouTube, and then the book right now, the best place is Amazon, just throwing my name in the search bar, Gina Mundy, or again, going to my website, ginamundy.com.
Awesome. Thank you so much for this wonderful conversation today that was so much easier to have than I wondered how it would go. I so appreciate you.
You know what though? I'm telling you, like the way that was perfect because you were like, hey, I'm a little bit nervous, I don't know about how today's going to go or whatever, but
I just wanted to be really upfront about that. I felt like I had no choice but to do that because if I came in with confidence, it was going to be false confidence. And if it went awry, it was going to be worse. So there you have it. Anyway, Gina, thank you so much for your time today.
Thank you, Tanya, for having me. I appreciate it.
Thank you for listening to the Mother Whip podcast. If any of the issues we discussed today resonate with you or your experience, I'd love to hear from you. Leave me a voicemail at 917-310-0573, or better yet, email me a voice memo at tanya@motherwhipmaternity.com. I really want to hear what worked for you, what didn't work, what support you'd wished you had, how you got through the tough times, how you advocated for yourself, or especially any tips you want to share with our listeners. I want to hear all of it. And if you'd really like to work together, you can get a discount on your first consultation with me at motherwhipmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. Okay, that's all. It's wonderful being in community with you all. Thanks again for listening, and see you next time.
And remember, listeners, nothing we discuss on this show should ever be considered medical advice. Please speak to your local provider about anything that comes up in this show that resonates with you and your needs and your health care.